Hello everyone, this is Chadi Alraies from NCVH 2023. I'm really privileged today to be with Dr. Frank Arena to talk about vascular access through the femoral artery and closure. Frank, thanks for being with us.
Oh, you're welcome. Thank you very much. So a lot of times, we still have to use the common femoral artery for a lot of different reasons. Maybe about a third of the time, or everything's not radial quite yet, especially peripheral cases. And a lot of times these are complex cases, using a lot of anticoagulation, and then you have to deal with the groin afterwards. Closure devices are great, but a lot of times they're done blindly. A lot of times the technicians will do it for you, and it's really we've basically just gotten into bad habits that we're just not dealing with the arteriotomy that we created, in my opinion, in the correct way. I think it goes back to the old days where we had these, very dedicated techs in the cath lab that would hold the groins for us. We could have depend on them to do a good job. But these days, those people just don't exist, and a lot of times the people having to deal with your groins, they're uneducated, they may be small, they may be weak. There's a variety of things that may not.
And we don't have them now anymore. I mean,
right.
You want them in the lab as much as you want.
Exactly. It may go to the floor. And, who knows what's going on? So I think I call myself a general contractor of cardiovascular services. So I think as any good general contractor knows, you have to clean up your mess. And so what we do is we do obviously ultrasound access, and a lot of people access in the short access where it just kind of looks like a circle, and it's hard to tell where you are in the artery and what's going on in the artery. We do that, but we also do it in the long access where we can see all the atherosclerotic plaque, as we've seen a lot of people doing angioplasty in the long axis. You get a lot of information in the long axis about a lot of different
to find
arteries.
a good spot where it's healthier.
Exactly. Where's the best spot to stick? Where you're not going to get in trouble with the closure device, things of that nature. And then on top of that, we close with the ultrasound. Okay, so we always make sure our stick's in a good place and to avoid problems, and then we close the ultrasound. So when we're closing, I have my ultrasound probe in one hand and the device in the other hand, and I have a variety of techniques that if I'm pulling the device back and the footer gets caught on something.
You're talking about like angioseal
or something with a footer-based device, and it gets caught on something, then I can deal with it. I can kind of advance it. I can turn it. I have a variety of techniques I won't go into here to pull it back and then get the footer up against the arteriotomy wall, and so it's deployed. Then you do a quick color. That you got good flow. There's no bleeding around it. Everything's good, and you can walk away from the table knowing that no matter how what person that patient runs into in the next hour, you're good.
Right, 100%.
You could have.
I never heard that technique before, but that's very interesting to learn.
We've been doing it to 10, 15 years. To be honest with you, I never really, at the very beginning of radial, I was like, oh, this just doesn't sound like a good idea. I thought they were going to be strokes, all this stuff. I was like, if the problem's the common femoral, we need to perfect the common femoral. So that's why I started to do it. And now I was wrong about radial, obviously.
Nice.
But we still have to use the common femoral some. So the effort was worth it.
Yeah.
And so in the last year, we've done a little bit of a registry. We did 129 cases in the last year. All comers, we closed 100% of them. Not again because we're trying to force ourselves to close it, but just because I feel I could close almost anything. And we're closing into stents. We're closing into just whatever it is, the most horrible vessels you can imagine. We were closing, and about I think 21 of them in that trial had more than 40% disease in the ultrasound tract, where we had to drag it back. 18 had to require additional manipulation.
So 18 cases or 18% you have to change?
No, it was 18 cases that you got the footer got caught on something.
So you had to change your basically technique.
Exactly, had to adjust.
Salvage.
Had to adjust, and it could have been a significant complication, but it wasn't.
That's
and we had no common femoral artery complications. We did have 2 late pseudoaneurysms, maybe a device failure or something, but nothing that an injection didn't. You had no
but that
bleeds.
explains sometimes you feel like you are walking away from a closure device, and you think it's good. All of a sudden they call you back. There's a hematoma
There's a problem, exactly, and that just really shouldn't happen because part of that's the stick, because a lot of times there'll be a little artery. Just because it's a common femoral doesn't mean there's not a little artery next to it.
Yeah.
and you may avulse, and you can see that. You go, oh, I better stay away from that.
Yeah.
And you
It happened with all of us.
Exactly.
Yeah.
Exactly.
And when you close a big one, there's this little guy oozing on you.
And so like 2 seconds of color afterwards to see that there's no flow around it. Or if sometimes there is a little bit of flow, okay, just get a pad and hold it. You know, or if there is, let's just say it just doesn't work out.
Yeah.
You know, sometimes you use these like I don't
Take
want
it
to
out.
be negative about a device,
course,
but a minx, like when you ultrasound do this, it kind of looks like a pseudo aneurysm ready to happen. You know, it's like let's just hold for a few more minutes.
Yeah.
You know?
So that's the whole thing of changing your closure
Exactly.
strategy. Yeah.
Exactly.
Is this registry only local or it's national?
It's local. It's just me, you
Okay.
know. And Craig was nice enough to. I showed him my work last year, and he was nice enough to let me talk about this
Nice,
year,
yeah.
which was nice. I'd like to get this out there, and you know, I think it's just it'll help some
Absolutely.
patients.
Yeah,
you know?
absolutely. Yeah. I'm looking forward to being print as well.
Oh, well, that would be awesome. Yeah, we'll talk to him about that.
Thank you so
All right,
much
thank
for
you
your
so
time.
much.
Please watch these videos and others on YouTube channel. This is Chadi Alraies from New Orleans. Frank, thanks so much for your time.
Great.
Thank you.
Yeah.